Hello friends, a very warm welcome to today's session. Dr. Anuradha Dhawan here, ophthalmology educator at Unacademy. Today we are going to discuss a very important topic, that is visual pathway field defects. I hope you will enjoy the session and have a good learning from this. Let's go ahead. So first of all, let's see what do we understand by visual field. Okay, so visual field, they mean the whole visual space or the space which we can see when our eye is centered at a central fixation point. Okay, that whole visual space will constitute the visual field. Okay, another important point to remember is that representation of the visual field in the visual space is exactly opposite to the representation of the retina. Okay, what do I mean by this? Now in retina, the macula or the fovea is your central fixation point. Okay, this fovea represents the central fixation point in the visual field also. Okay, but the superior part of the retina, the superior half of the retina is responsible for the inferior visual field. The inferior half of the retina is responsible for the superior visual field. The nasal half of the retina is responsible for the temporal visual field, and temporal half of the retina is responsible for the nasal visual field. Okay, so let me just repeat once again. The representation of the visual field is opposite to the representation in the retina. Okay, so if we are talking about the right eye visual field, just concentrate here. The center of the visual field corresponds to your central fixation point, that is fovea. Okay, the upper half of the visual field is by the inferior retina. Okay, the inferior half of the visual field is by the superior retina. The nasal half of the field is by the temporal retina, and the temporal half of the field is by the nasal retina. Okay, so that is why the blind spot, this is your blind spot, the blind spot in the visual field is temporal to the central fixation point. Temporal, because the blind spot is due to optic disc. Optic disc doesn't have any photoreceptors, so there is a absolute scotoma at that spot in the visual field, which is called blind spot. In the retina, the optic disc is nasal to the fovea, but in the visual field, the blind spot is temporal to the fovea. Okay, because of the representation which we just discussed. Okay, so when we are doing perimetry, we get this kind of field. This is representing normal visual field. Okay, so here this central point is your fovea. This is the blind spot of the left eye. This is the blind spot of the right eye. Okay, when we are describing the visual field abnormalities, so we can divide the abnormalities whether they are present in the superior half of the field or inferior half of the field, which is divided by a horizontal meridian. Okay, so this will be your horizontal meridian, or we can define the visual field defect as whether it is involving the nasal half of the visual field or temporal half of the visual field, which is separated by the vertical meridian, Okay. Now at the outset only, I would like to emphasize this point, that the visual fields which are resulting from the lesions of the visual pathway, they respect the vertical meridian. Okay, they respect the vertical meridian, that with either they will be in the temporal half or in the nasal half. Okay, so vertical meridian will be respected in the neurological visual field defects. Okay, so I hope we are now comfortable with the terms central fixation point, blind spot, the two halves of the visual field, temporal half and the nasal half. Okay, now moving on to another important concept of the anatomy of the visual pathway. Let's revise it once. We know the visual pathway starts at the retina. Okay, neurosensory retina. The axons of the ganglion cell, they form the nerve fiber layer, and the nerve fiber layer forms the optic nerve. Okay, optic nerve starts at the optic nerve head. Okay, and it ends at the optic chiasma. Okay, at the optic chiasma, very interesting thing is happening, that is the nasal fibers of the two sides which are coming from the nasal half of the retina, they are crossing or decussating. Okay, after crossing they go to the opposite side. The temporal fibers, they remain on the same side, so that the optic tract which is there after optic chiasma, the optic tract contains the temporal fibers from the same eye. It is containing temporal fibers from same eye and nasal fibers from opposite side. Okay, nasal fibers from opposite side. Now from the optic tract, the fibers, they synapse in the lateral geniculate body. From the lateral geniculate body, the optic radiations, they start. The optic radiations, they have to synapse at the visual cortex. Okay, so they synapse at the visual cortex. But before moving to the visual cortex, some optic radiations, they go through the temporal lobe and some they pass through the parietal lobe. Okay, the fibers which are responsible for the superior field, they go through the temporal lobe, making a Meyer's loop, and the radiations which are passing through the parietal lobe, they are making a Baum's loop. Okay, and then they reach the visual cortex. In the visual cortex also, one point to be noted is that the fibers which are responsible for the macular area, are present at the tip of the occipital cortex. Okay, and that area is usually gets supplied from both the posterior cerebral artery as well as from the middle cerebral artery, whereas rest of the visual cortex gets its supply from the posterior cerebral artery only. Okay, so this has the implication that if it is an occipital lobe lesion, which is usually due to infarction as a result of the posterior cerebral artery involvement, the macular fibers will be spared. Okay, we'll be discussing it, that how the different field defects are produced. Okay, so our optic nerve, decussation at the optic chiasma, optic tract containing temporal fibers from the same eye, nasal fibers from the opposite side, temporal radiations, parietal radiations, visual cortex. Okay, so this is how the visual pathway, the important landmarks are there. Now, visual fields. Coming to the visual field defects, again, let's have understanding of few important terminologies which we'll be using. Hemianopia. So as the word is suggesting, there is loss of one half of the field, either the nasal half or the temporal half. If that is the case, we use the term hemianopia. Okay. The second is your quadrantopia. If there is a loss of quadrant of field, okay, then we use the term quadrantopia. Then there are two terms, homonymous and heteronymous. The field defects, they are said to be homonymous. or heteronymous. What do we mean by this? Okay. Now, homonymous means the field defect is involving the same sides of the visual space. Okay. So, if this is the visual field of the left eye, this is the visual field of the right eye, in a homonymous field defect, this is your vertical meridian. Okay. In a homonymous field defect, the field defect will be involving the same side of the visual space. Okay. So as you can see, it is the same side. It is the nasal field of the left eye, temporal field of the right eye, but it is on the same side of the visual space. So such a field defect is known as homonymous field defect. Whereas in heteronymous field defect, the field defects involve the opposite half of the visual space. So if this is left eye field, this is right eye field, in heteronymous, it will be affecting the opposite side of the visual space. Okay. So please concentrate on the words opposite sides of the visual space. So this, which is involving the temporal half of both the eyes, is actually opposite sides, and this is your heteronymous field defect. Whereas this is on the same side of the visual space, this is your homonymous field defect. Okay. Then another two terms which are used to describe the visual field defect is your congruous and incongruous. Congruous means that the visual effect which is there in the two eyes is almost identical. It is symmetrical. Okay. Whereas with some dissimilarity, like it is not completely mirror image of the field defect in the other eye, then it is known as incongruous field defect. Okay. So these are the terminologies or the descriptions which we use when we are describing the field defects. Now let's move on to the what type of the visual field defect will be produced when there is lesion at the different parts of the visual pathway. Okay, let's go step by step. Here the anatomy of the visual pathway will help us. Now starting at the retina. If you look at this point A, you know if retina, especially when the macula is involved, then it will be producing the central scotoma. There will be a field defect involving the central field, which is known as central scotoma. Okay. If the lesion is involving the optic nerve, if whole of the optic nerve is involved, then it will produce a monoocular vision loss. The vision loss will be there only on the side of lesion, same just like the macular defect, but it will be depending upon the severity of the lesion. It may involve as a central or centrocecal scotoma or complete field loss on the same side of the lesion, Okay. Now coming to the optic chiasma area. We know the central part of the optic chiasma contains the nasal fibers of both the sides which are crossing. So if there is a lesion which is involving optic chiasma, mostly the compressive lesions, they will be damaging the nasal fibers of both sides. So if the nasal fibers of both sides are being damaged, they will be producing temporal field defect on both the sides. So this is your bitemporal field defect which is produced in the lesions of optic chiasma. And we can now clearly see this defect is what we call as heteronymous defect because it is on the opposite side of the visual field space. Okay. Now, if the lesion is at the optic tract, after the chiasma comes your optic tract. If the lesion is at optic tract, now remember, optic tract is containing fibers from both the eyes. It is containing nasal fibers from the opposite eye and temporal fibers from the same eye. So it will be producing again defect in both the sides, but it will be involving the same half of the visual space. That is, it will be producing a homonymous hemianopia, same half of the space. Okay, which half? Now again important to remember that optic tract onwards, okay, starting from optic tract onwards, lesion of one side will produce contralateral hemianopia. Okay, contralateral hemianopia. It means if the optic tract of right eye, like in this case, if optic tract of right eye is affected, then the left half of the visual field in both eyes will be affected. Left half of the visual field in both eyes. Okay, so same half, left half of the visual field in both eyes. So we will call this defect as contralateral homonymous hemianopia. Hemianopia half, homonymous same side. Which side? Opposite to the side of lesion. Okay, so am I clear? I'll repeat once again. Hemianopia, half of the field gone. Homonymous, same side of the field gone, same side of the visual space gone. Okay, which side? Contralateral side. So right eye optic tract will produce left-sided homonymous hemianopia. Okay, and this laterality contralateral now will stay same whether the defect is in optic tract or it is in lateral geniculate body or in radiation or in the occipital cortex. The defect will be on the contralateral side of the visual field. Okay, now after the tract, if the lesion is in radiations, okay, so first of all, if the part of the radiation which was in the temporal lobe is affected, okay, now the temporal lobe fibers are responsible for the superior field. So if the lesion is in that part of optic radiation, we get a quadrantic effect. Superior quadrantic effect, quadrantopia, contralateral, and the appearance of the defect has been given the name pie in the sky. Pie in the sky, because it is a superior quadrantopic defect. Okay, contralateral. Coming to position F. If the lesion is in the parietal part, parietal lobe, the part of the radiations which were passing through the parietal lobe are affected. Now these fibers are responsible for the inferior field. So again there is a quadrantic defect. Now this quadrantic defect is in the inferior quadrant and it produces a lesion that is pie on the floor. It produces the lesion pie on the floor. And last, if the occipital cortex is involved, if the occipital cortex involved, that also produces homonymous hemianopia, just like the optic tract lesion. But this homonymous hemianopia is different. That is, there is sparing of the macular field. There is sparing of the macular field. I told you why. Because the macular area gets dual blood supply. Most of the lesions are because of the occipital lobe infarction. That is due to the posterior cerebral artery involvement. Now, in those cases, there is macular sparing because this part gets supply from both the middle cerebral as well as the posterior cerebral artery. If there is a lesion involving the tip of the visual cortex, tip of the occipital lobe, now this type of lesion usually we see in cases of trauma. So if the tip of the occipital lobe is involved due to trauma, then the macular field is gone. That area is directly damaged in those cases. Then the macular field is gone. Okay. So I will make you revise this with the help of the different field defects in a more magnified view. Okay, so first of all, let's see how does the bitemporal hemianopia looks like. Bitemporal hemianopia, opposite half of the field is gone, that is temporal side of both the eyes. The lesion responsible for this is chiasma, because chiasma is containing the nasal fibers. Okay, this type of the hemianopia is called heteronymous hemianopia. What are the common lesions which affect the chiasma? Mostly the compressive lesions because of pituitary tumors, that is pituitary adenoma or craniopharyngioma, or aneurysms of the arteries which are close by. Okay, so the compression of the nasal fibers leads to bitemporal hemianopia, which is seen in chiasmal diseases. Moving on to homonymous hemianopia. Homonymous hemianopia, same side of the field is gone. Okay, it is a contralateral defect, that if right side of the brain is involved, the left side of the field will be gone. Okay, now homonymous hemianopia can be seen in optic tract lesion as well as in the lesions of occipital cortex. Okay, but occipital cortex will be associated with macular sparing. It will be associated with macular sparing. Okay, one point to be noted about the optic tract lesion, that is the fibers which are responsible for the pupillary reflex. For the pupillary reflex, they also follow the visual fibers till optic tract. From optic tract, the pupillary fibers, they go to pretectal nucleus, whereas the visual fibers, they go to, as we just learned, lateral geniculate body. Okay, so after optic tract, that is the lesion of lateral geniculate body, the lesion of radiations, the lesion of occipital cortex, they will not have any pupil involvement, because pupillary fibers have already gone to a different pathway. Okay, but the optic tract is containing the pupillary fibers from one half of both the eyes, because it is containing half the fibers from both the eyes. So involvement of optic tract lesion is associated with a very interesting pupillary defect which is called Wernicke's hemianopic pupil. Wernicke's hemianopic pupil. Okay, so Wernicke's hemianopic pupil, please remember, is seen in optic tract lesions. In this, actually, when we are shining light, we are stimulating the retina with light, the pupil should constrict. Okay, but since optic tract, if it is affected, that is containing the fibers from one half of the retina, so when you shine the torchlight on the healthy half of the retina, the pupil will constrict. But when you will shine it on the part which is affected, the pupil will not constrict. So this kind of pupillary defect is known as Wernicke's hemianopic pupil, which is seen in the cases of optic tract lesion. Okay, superotemporal quadrantopia. So superotemporal quadrantopia, pie in the sky appearance. As we just learned, revising once more, this is seen in the temporal lobe lesion, the optic radiations which are passing through the temporal lobe. Infratemporal quadrantopia, the pie on the floor. Now again, please concentrate, both pie on the sky and pie on the floor are again homonymous lesions, homonymous on the same side. Okay, they will be same side of the visual space. They will be contralateral to the side of the lesion. Okay, so pie on the floor seen in cases of parietal lobe lesions. Occipital cortex, once again, as I told you, the macula will be spared. So this is how a macula sparing homonymous hemianopia will look like. As you see, the hemifield is gone, homonymous hemianopia, but the central field which is representing the macula is spared. This is typical of occipital lobe lesion due to infarct involving posterior cerebral artery. Okay, then another important concept to be made is junctional scotoma. What do we mean by this? Okay, now junctional scotoma is a kind of defect in which, as you see, this is left eye, this is right eye. Now what happens in this kind of scotoma? There is a complete field loss in one eye. Okay, there can be complete field loss or a central or centrocecal. Okay, that is the optic nerve field defect. Centrocecal field defect, that is optic nerve involvement in one eye. Okay, and a superotemporal quadrantic defect in the other eye. Superotemporal quadrantic defect in the other eye. Okay, so this type of field defect is known as junctional scotoma. This is produced in the lesions in the part of the optic nerve just before the optic chiasma. Just before the optic chiasma. Okay, why this is produced? So this is your optic nerve, this is your optic nerve, this is the chiasma. Now what actually happens? The nasal fibers, they are to cross on the other side. Okay, but the inferonasal fibers, they do not cross directly. They make a loop in the opposite optic nerve and then they cross to the opposite side. Now if the lesion is in this area which contains the fibers from the opposite optic nerve, so the lesion will be on one side, left-sided optic nerve. The lesion is only on the left-sided optic nerve, but this is containing these looped fibers from the right eye also. So this produces a corresponding field defect, that is superotemporal quadrantic field defect in the right eye also. Okay, so this looping is your bending of the, or the knee of the Willebrand, it is called. This bending of the fibers is given the name knee of Willebrand. And this anatomy is responsible for junctional scotoma if the field defect is in this area, the posterior part of the optic nerve, just proximal to the optic chiasma. Okay. Okay, a quick recap what we did. Let's have a recap so that we are clear, and in the end we will be revising with the help of few MCQs so that our concepts are consolidated. So coming to figure number 1. Can you tell me what kind of field defect are we seeing here? Figure number 1. So yes, the figure number 1 is your bitemporal hemianopia. This is your bitemporal hemianopia, which is seen in the lesions of chiasma when there is central, the compression of central chiasma. Okay. Figure number 2. Complete homonymous hemianopia. Now this, which sided hemianopia? This is the right side of the visual field. So this is right-sided homonymous hemianopia. So this complete homonymous hemianopia will be seen in optic tract lesion. And since it is a right-sided defect, so left optic tract lesion. Okay. Moving on to the image number 3. We can see a quadrantic defect over here, superiorly, pie in the sky, right-sided. So this is your left temporal lobe lesion. And the type of the defect which we are seeing in this figure is pie in the sky. Okay. Coming to figure number 4. Inferior quadrantic defect, pie on the floor. The pie on the floor is seen in cases of parietal lobe lesions. It is a right-sided defect, so it has to be left parietal lobe lesions. Okay, so are we clear with this? First of all, moving to figure number 6, and later we will come to figure number 5. Figure number 6, hemianopia but showing macular sparing. Hemianopia but showing macular sparing. So this is seen in occipital lobe lesions, occipital cortex lesion, especially the infarction. Okay, and number 7, I think you can very well identify now. Complete field loss in one eye, superotemporal quadrantic defect in the other eye. The field defect is your junctional scotoma. And this is seen in the lesions of optic nerve proximal to chiasma. Okay. Now coming to this particular image. Now lateral geniculate nucleus involvement can produce hemianopias. Okay, it can produce hemianopias, but it can also produce quadrantic defects or sectoranopias, that a particular sector may be involved. Okay, so these defects, if you are come across these kind of defects, they are due to lateral geniculate body involvement, and they are your sector defects, also known as keyhole field defect. So keyhole field defect is seen in the lesions of lateral geniculate body. So I'm sure now this slide has summarized the different type of the field defects which we see and what lesions are responsible for the production of these defects. Okay, now let's go through few MCQs so that we imply the knowledge which we have just learned. Okay, coming to the first MCQ. Now, a 50-year-old man has presented with deteriorating vision. On examination, he has bitemporal hemianopia. What is the most likely site of lesion? Left occipital lobe lesion, optic chiasma, left optic nerve lesion, right parietal lobe. Okay. Now, the word bitemporal is quite straightforward. We know the bitemporal will be produced if the nasal fibers are damaged. Nasal fibers are damaged both sides at the position of optic chiasma. So optic chiasma is the place where nasal fibers are crossing. So this kind of the field defect has to be produced by a lesion in optic chiasma. Optic nerve lesion will have only uniocular field defect. Okay, except for the junctional part. Okay, the occipital lobe lesion or the parietal lobe lesion, they produce homonymous defects, not the bitemporal defects. Okay, so the right answer to this question is optic chiasma. Now, incongruous hemianopia with Wernicke's hemianopic pupil is seen in the lesion of visual cortex, optic tract, optic radiation, optic nerve. Okay, just remember what we learned. Wernicke's hemianopic pupil. Wernicke's hemianopic pupil is seen in the lesions of optic tract. Hemianopia is also seen optic tract lesion. The optic tract defects are incongruous because they are not exactly symmetrical. There is usually asymmetry between the field defect. Okay, so incongruous hemianopia with Wernicke's hemianopic pupil, please remember, will be seen in optic tract defect. Visual cortex, no pupil abnormality. Optic radiation, no pupil abnormality. After optic tract, the pupil is not affected. Okay, optic nerve will lead to RAPD or absolute afferent pupillary defect, not the hemianopic type. Okay, so the right answer to this question is optic tract. Then, what is the most likely diagnosis from this perimetry finding? You can see a perimetry finding given along with what is the most likely diagnosis from this perimetry finding. Is it optic neuritis, occipital infarct, advanced glaucoma, or pituitary adenoma? So first of all, try to identify what type of the field defect it is. Okay, so this is the temporal part of the field defect on the both sides is gone. So this is your bitemporal hemianopia. Agree? This is your bitemporal hemianopia. Now this type of the defect we know is produced by chiasmal lesions. Chiasmal lesions. Okay. So out of this, what can cause the chiasmal lesion? Your pituitary adenoma. Pituitary adenoma. The glaucoma defects are not like this. Okay. They respect the horizontal meridian. Occipital infarct will produce homonymous defect. It will produce homonymous defect. Optic neuritis will produce, if it is on one side, then it will be producing uniocular defect, which is mostly the case. Okay. So this bitemporal will be your chiasmal lesion due to pituitary adenoma. Okay. Okay, coming to this question, which of the following could be the likely cause of the given field defect? Another image of the field defect has been given to you. So you have to identify which type of field defect is this and what could be the cause. Okay. Is it a right parietal lobe lesion? Is it a left parietal lobe lesion? Is it a right temporal lobe lesion or left temporal lobe lesion? Okay. Now we are one step ahead that we have to tell the side also which side is involved. So first of all, identify the defect. It is your superior quadrantic defect. Which side? This is right-sided defect. This is right-sided. So studying the visual field, it is on the same side as you are. Okay. So right side of your body is the right side of the visual field. Okay. So right-sided visual field defect. Now right-sided pie in the sky will be produced by left temporal lobe lesion. Right-sided pie in the sky will be produced by left because the defect is contralateral. Optic tract onwards, the defect is contralateral. So parietal lobe produces inferior defect. So these two choices are gone. Since it is a right-sided visual field defect, it cannot be due to right temporal lobe lesion. It is due to left temporal lobe lesion. Okay. Okay, coming to the last MCQ. No, one more is there. A left macular sparing homonymous hemianopia is characteristically associated. So again, a revision which I have told you now repeatedly. Macular sparing homonymous hemianopia. So these words should ring that lesion is in occipital cortex. Macular sparing. Okay. So this choice is gone. This choice is gone. Okay. So we have these two occipital lesions. But if it is macular sparing, it means it has to be due to mostly posterior cerebral artery infarct, because middle cerebral, if it is involved, that will rather involve the macular fibers also. Okay. So the PCA infarction will lead to right-sided PCA infarction will lead to left macular sparing homonymous hemianopia. So right answer to this question is your choice C. Choice C. Okay, the last question of the session. The following visual field abnormalities are correctly paired with the likely cause. So here we have to mark that which one is the incorrect pairing. Incorrect pairing. So let's go through. Bitemporal hemianopia, pituitary adenoma. So bitemporal hemianopia means the lesion has to be in chiasma. So this is correct pairing. The right homonymous hemianopia with left occipital lobe lesion. Yes, it can be, though they have not mentioned whether it is macular sparing or not, but yes, right homonymous hemianopia with left lobe lesion, contralateral. Okay. Monoocular total field loss with optic nerve injury. Yes, that is true. Right homonymous hemianopia with right occipital lobe lesion is false because the lesion has to be contralateral. The right homonymous hemianopia has to be due to left lobe. If it is right lobe lesion, that will produce left homonymous hemianopia. Okay, so this is the right answer to this question. Okay, so this brings me to end of this session of the visual field defect in cases of visual pathway lesions. Okay, so thank you very much for joining in the session. All the best for your future learning, and I'm sure you are going to succeed in all your effort. May God bless you. Thank you very much.